All right, then we'll start. Good evening, everyone, and welcome to another edition of webinar from your very own Bootcamp 2.0. We are back today with a very interesting topic, pediatrics. We'll be walking you through a variety of common case scenarios you will encounter in your general OPD, their management, things to keep in mind while treating a pediatric patient, and how to prescribe for a pediatric patient. The speakers for today's webinar are the extremely talented pediatricians, Dr. Mark D'Souza from the batch of 2016, currently pursuing his postgraduate degree in pediatrics from St. John's Medical College, Bangalore. Next, we have moderating this session, Dr. Nikit D'Souza from the batch of 2010. He's the assistant professor in the pediatric department of St. John's Medical College, Bangalore. Okay. A few things to remember while attending this webinar. Kindly keep yourself muted during the session, but please do put your doubts and queries in the chat box, which you'll find on the bottom corner of your screen, and we will try to answer all of your doubts and queries by the end of the session. Okay. This webinar will be divided into two sessions. First will be taken by Dr. Mark D'Souza, followed by a 5 minutes break, where we will be sharing a link to a feedback form to help us guide you better. This will be followed by the session by Dr. Nikit D'Souza. Okay, handing over to Dr. Mark to start this session.
Yeah. All right, just show, am I audible?
Yeah, you're audible,
All right, guys. So we'll try to keep this brief and informative. As far as possible, we would like your participation as well. We've tried to focus on some of the more common things that you will see during bond. So an overview of what the presentation will contain. One, and perhaps the most important, is a bonder's toolkit. What are the things that you would probably want to keep ready on your OPD table or handy on your phones to properly, address the needs of a pediatric population. As a lot of you have requested, we'll be covering fluids to a very basic degree in terms of what you absolutely need to know. How to address fevers and common scenarios we encounter in fevers, common consultations which we would encounter on a day-to-day basis during bond, the dengue dilemma given the climate we live in, and IMNCI, the conditions which are covered under that. Into a bonder's toolkit. The things that you would need apart from what your usual getup, apart from your stethoscope, your BP apparatus, things that we would recommend all of you will have is measuring tape. Naturally, to ensure that you are properly tracking the anthropometry of your children. Something that we commonly instruct interns at the start of our pediatric posting, and we ask them is, what are the things that you would commonly measure in children? So would anyone like to tackle that? What are the common things that you would measure in a child less than 5 years old and a child more than 5 years old? You all could unmute because I'm not able to see the chat box right now. Anyone? All right.
I don't think anyone's going to answer.
Okay, fine. So a little bit of a shyer audience then. Okay, so for children less than 5 years, you would want to measure the weight, the height of the child, the head circumference, and the mid-upper arm circumference. This goes hand in hand with point number 3, the WHO and IAP charts. So where we would plot these and be able to tell whether the child is appropriate for their age, whether they are underweight, whether their head circumference is on the lower side or higher side, all of which would grant us useful information. For children over 5, we would want to measure their weight, height, and calculate their BMI. Point number 2 is a torch, definitely an essential part of your pediatric toolkit, because we would want to measure, we would want to check, the children's throat, their nose. the growth charts, of course, the developmental milestones. So what we would recommend is in your guy, it's given quite well, all of the developmental milestones, and that is taken straight from Illingsworth, which is the Bible of development. Something else that we'll cover in the course of this talk is the Trivandrum Developmental Scale Chart. And Harriet Lane. I'd say that as a pediatrician, it's necessary that everyone has a Harriet Lane, but even before that, when you're pursuing your bonds, Harriet Lane is a very useful guide towards drug dosages and even management of a lot of common conditions. And point number 6, perhaps the most important, a little common sense. It's as they say, when you hear hooves, think horses and not zebras. So thinking about what is the most common in each scenario is probably what would guide you to the right diagnosis. So coming towards fluids, as we all know, fluids is estimated. A child's daily 24-hour requirement is estimated by the Holliday-Sagar formula, which says, as the slide depicts over here, that for the first 10 kgs you would give a child 100 ml per kg. The second 10 kgs 50 ml per kg per day, and beyond that, you'd give the child 20 ml per kg per day. Now, dividing all of these numbers, 100, 50, and 20 by 24, would enable us to know how much the fluid rate for this child would be, because 24 hours in a day. So dividing 100 by 24, you get 4. Dividing 50 by 24, you get 2. And dividing 20 by 24, you get roughly about 1. So this is how we would usually calculate fluids. So for a child weighing 15 kgs, it would be 10 into 4 plus an additional 2 into 5. Giving us a fluid rate of around 50 ml per hour, and multiplying that by 20 would give us how much fluids they would daily require. This is just their maintenance fluids. Have you understood that, or would you like me to repeat that? Just a thumbs up in the chat or something would perhaps do. Understood? Okay, so for children, the usual maintenance fluid that we choose is DNS. And for infants, that is children less than 1, what we would usually choose is half DNS. So this is a fluid that you would usually want to choose. In a lot of burn centers, we have ISO-P and all, which was used in yesteryear, but now in modern day times, it is very clearly given that these are the of choice. In cases of dengue, we have a child who's irritable, thirsty, with stable vitals. Oral mucosa is dry with tears absent. Systemic examination is unremarkable. Would anyone want to venture a guess as to what we're talking about here? Anyone?
You can pick your person, Mark.
Dhani says
No,
acute in the chat.
Acute G. Okay, and can we do we know any way to stratify acute G in terms of the dehydration? I can't see the people, Nikit. So perhaps you could choose, Nikit.
No, I think no. Dhwani has answered. So if you want, you can go on with her.
Okay.
The questions I will answer on the group. I mean, I will answer on the messages.
Okay, fine. Sure. All right. So we're talking about acute GE, and specifically in this scenario, we're talking about diarrhea. So what I want you to convey through this is that while GE, AG, and diarrhea for that matter are predominantly infective in etiology, when we're talking about an acute episode, viral tends to be the most common etiology. So one thing that you will commonly encounter during bond is when the child has had acute GE, they would have gone to a local practitioner. They would have started them, as point number 3 over here says, antibiotics tend to worsen the gastroenteritis. And so it is important in these scenarios, after properly evaluating the child, ensuring that there is no fever associated with this, ensuring that there is no blood in those stools, and ensuring that it doesn't fall under the definition of a cholera-like stool, which is a watery rice water stool. Once we are sure that it is none of these three, to have those the confidence to stop those antibiotics, because in a lot of times just stopping that antibiotic will tend to improve the loose stools dramatically. The next stage would be to, as it depicted in the case scenario, stratify their dehydration status. So going from right when they enter your OPD, seeing the sensorium of the child, whether the child is irritable, whether the child is very, very lethargic looking, or whether the child is normal looking. Then going and assessing from head to toe. So for children who before the age of AF fusion, assessing whether your AF is at level or whether it is sunken, looking at their eyes and seeing whether the child has sunken eyes, opening their mouth and using that torch that we've ensured that we have, and seeing whether the child has a wet oral mucosa as normal or whether the child has a dry oral mucosa, and going a little lower onto their abdomen and checking for the skin pinch, to seeing whether the skin pinch goes back normally or whether it's going back very slowly. This would help us to stratify the child into your severe, some, and no dehydration. Now, no dehydration can definitely be managed on an OPD basis, and in this case, you would all you would have to do is teach them how to mix ORS and encourage them to give the child a lot of fluids. What is important in these cases is, and we've seen a lot of times people giving the wrong advice as to have a lot of juice. Now, when you're specifying juice, you probably want to tell them to not buy these Tetra packs. For that matter, ORS in itself, it's important that they make freshly prepared ORS, mixing that sachet of ORS in 1 liter of water and giving the child appropriate amounts, as opposed to buying the Tetra packs, which in themselves have an incorrect proportion of all your electrolytes and could also worsen your dehydration. Home available fluids, your rice water, your kanji, even coconut water for that matter. These things are something that the other things that you would generally advise them to have. Apart from this, advising them to take zinc supplements. So for children less than 6 months, you can usually the available in villages is the 20 mg tablet. So asking them to have half of that tablet, you could advise them to crush it and give it along with water. Or if your centers have ZND or any zinc syrup, giving them 0.5 ml of a 20 mg syrup once a day for 14 days. And for children older than 6 months, giving them 1 full ml once a day for 14 days is what you would advise for a no dehydration correction. For children with some dehydration, over here is where it's important to give them a stat dose of ORS. This is where our concept of ongoing losses, dehydration correction, maintenance fluids comes to the picture. So when we have any amount of dehydration, that's where your third component of dehydration correction comes into being. For every child, we have to ensure that they have a certain amount of maintenance fluids, as indicated by the Holiday-Segar formula, an ongoing loss. So what we usually advise is anywhere between 5 to 10 ml per kg of ORS for every large quantity stool, or for every 3 small to correct the ongoing losses. Maintenance fluids would remain as they are. And so the way that is significant, and the way it's important to be communicated out to the parent, is by telling them roughly in 2 hours how much you would want them to have. So for instance, for a 5 kg child, we would say that going by a Holiday-Segar formula, the child would have to have about 50 ml of fluid per hour. So roughly telling the parents that for every 2 hours, ensuring that the child has 100 ml of fluids, and for every 3 small quantity loose stools, the child has an additional 50 ml of ORS, would be an appropriate way to communicate how much fluids you would want them to have. Okay. Now, if the child also has vomiting in these scenarios, and it's an uncontrollable vomiting, not amenable to medication, which we will come to, In these cases, we would probably consider admitting the child to administer fluids until the symptoms were to resolve, at least the vomiting were to resolve. Severe dehydration, in these cases, you would want to refer the child, but you could, if your center is amenable to it, you could definitely consider giving this first correction with 100 ml ringer lactate solution. So you would give 100 ml per kg, it being divided into a first 30 ml per kg and then a remaining 70 ml per kg. So that first 30 ml would be given at a faster rate. So 30 ml per kg in 1 hour, it would effectively be like a bolus. And subsequent to that, you would give 70 ml per kg over 5 hours. This is in cases of infants. And for anyone above that, up to 5 years, you would give the first 30 ml per kg over half that time, half an hour, and the remaining 70 ml per kg over the next 2.5 hours. So let's consider again another example. We'll go to that same 5 kg child who would probably fall in the infant age group. This child would require 150 ml to be given in that first hour. So your fluid rate at that point would be 150 ml per hour, with 150 ml, ensuring that you stop that fluid rate after 1 hour. Subsequent to that, the child would require 70 ml into 5. So that's 350 over 5 hours. So the fluid rate that you would chart and you would instruct your nurse, or you yourself would start, would be 350 divided by 5. So you would give the child 70 ml per hour over the next 5 hours. This would just address the dehydration correction. Now, in addition to this, you would also want to ensure that the child is also getting their maintenance fluids. So if the child is taking orally, you can ask them to encourage the mother to drink, to feed the child. Or if they are not, again, starting a second IV line and administering your IV maintenance fluids as per the fluid rates previously elucidated. And then if you feel you can manage the child, you can manage them over there, because this is all these 3 scenarios are scenarios that you can actually handle at a burn center. But if you feel that your center is not well equipped to handle pediatrics, then you would look at referring them to a higher center at this point. Coming to the role of antibiotics. Now, as I have said earlier, antibiotics are a big no-no when it comes to diarrhea. But the few conditions where you would consider giving an antibiotic would be infants less than 3 months, children with immunodeficiency, because as we all know, immunodeficiency means that they will not react to infection as a normal child would. So these are children who are more prone towards infections, especially bacterial infections, and therefore would require some amount of antibiotic cover to address the current condition, acquiring other conditions. SAM children, and then your various bacterial infections, Shigella, E-tech, Vibrio cholerae, and Yersinia enterocolitica. So the usual antibiotic that we would choose. So first I will cover for Vibrio is if you establish that these are rice watery stools, what you could do in these cases is for children older than 2 years of age is you would give a start dose of doxycycline between 2 to 4 mg per kg. So generally, we would go on the higher end of that spectrum, 4 mg per kg. So for a child, maybe now we'll consider a different example, a slightly older child, more around 2.5 years, weighing about 15 kg, we would give 60 mg. So this comes as a 100 mg tablet doxycycline. So you would give a little over half of that tablet to that child immediately. Things about doxy is it causes very severe gastritis, so you may want to give the child a pantoprazole as well and ensure that they have something to eat as well. For other conditions, generally the antibiotic of choice would be your third generation cephalosporin. So you would think of ceftriaxone if you're giving IV, or you would give cefixime as an oral medication, which would come as 10 mg per kg per day in 2 divided doses. So we'll come to the later slides which will show you the formulations. We'll come to that at that point. Okay, so returning back to our 4-year-old girl, the child, you have connected IV fluids, so hydration status is intact. But now you notice that the child is vomiting and orally. The child refuses oral feeds on account of vomiting. So this is where we would address the next thing that you have told us to cover, antiemetics. It is at this stage that you would consider giving an antiemetic if your medicine and you're not able to hydrate the child simply because of vomiting. So the usual go-to antiemetic that we choose is ondansetron. You could give it per oral, and we will generally prefer to give it as an oral formulation first. And if that's not reaching the child still continues to vomit, in those cases, you will consider giving IV. So the general dose of ondansetron is 0.15 mg per kg, and the maximum amount you would give per dose is 4 mg per kg. As an IV formulation, and you can, as enlisted over here, there are various weight bands as per Harriet Lane specifying how much you would give for each child. Now, oral disintegrating tablets are available, but more commonly we have our syrup. So it usually goes by the brand name of Vomikind in a lot of burn centers, where you have about 2 mg for every 5 ml. So if you wanted to give, 2 mg for every 4 mg for every 5 ml. So if you wanted to give a child, our same child, 4 mg for every 5 ml.
2 mg for 5 ml.
2 mg for every 5 ml, yeah. So for an older, the same child of 15 kgs that we were just talking about, you would give 5 ml of that setup as a stat dose. But in case that is not available, we would give 15 into roughly about 0.2. That's about 3 mg IV you could give this child. Okay. So that is how we would address your AG. Again, please do mention all your doubts, and Nikith will revert back to you. We will move forward with fever. So coming to fever, you have a 2-year-old boy baby brought by his mother with complaints of fever since 3 days. She tells you, doctor, this child is having fever throughout the day. His head is feeling really warm. On examination, you establish the child is well looking, febrile at that time, temperature of just about 98.5. Child is hemodynamically stable with systemic examination unremarkable. What do you do in these circumstances? Okay, we still have a little shy audience. So what is important to note in these cases is to know whether it truly is fever. Now, in a child who is well looking, even if it is a febrile condition, it's most likely going to be a viral fever. So what you would do in these cases, especially if they are not quantifying the fever, is to ask the mother to actually grade the fever and to measure this. In these cases, the only thing to prescribe would probably be to prescribe a thermometer. What you would do is draw a chart saying morning, afternoon, and night, and list out maybe for the next 2 days. You specify the dates and ask them to measure the child's temperature every time they feel that the child is febrile, and to only give paracetamol if the child is having a fever that is over, as mentioned over here in Nelson's, they talk about rectal temperature greater than 38 and a temperature of 100.4. But what you would usually check is axillary temperature. So any temperature over 100 is what we would consider as actual fever. The next thing that you would do is try to evaluate for a focus. Common foci that you wouldn't want to miss are, 1, your throat. So you would do an oral examination. Number 2, you would want to also check the child's ear. So always complete your ENTs altogether, ear, nose, and throat. Ensure that the child isn't having, inflamed mucosa or reddened tympanic, an angry-looking tympanic membrane. And then you would do your general systemic examination. Check the RS for any creps. Do an abdominal examination. Evaluate for coexisting features of infection, any coexisting symptoms. And then decide on your disposition as to whether you would want to actually give an antibiotic. So this is the consensus guidelines by the IAP as to which children you would treat and how you would go about identifying whether or not the child warrants any treatment altogether. So this I will leave over here and allow you all to go through. The general dictum would be that well-looking child, by and large, it would just be a viral fever, not warranting any antibiotics, but a toxic-looking child requiring further evaluation. So you may even want to withhold sending a CBC unless the parents have actually documented temperature and it's going past the period of a viral fever. So once it enters that 3 to 5 day period is when you would generally look at investigating, especially given the times we live in with dengue in season currently, amok. Treatment, to decide on whether you want to admit the child or treat them on an OPD basis, the general things that you would look for is whether the child's ABCs for one are intact. Conditions where ABCs may be compromised would include things like croup. For children in the neonatal age group, so when it's a neonate, there you have a completely different workup altogether for fever, and in these cases you would want to admit the child. If the child has had a history of seizures or is actively seizing in front of you, in those cases you would want to admit the child. If the child just generally does not look well, when there's signs of dehydration, if the child is breathing fast, if the child's hemodynamics are compromised, these are the conditions where you would consider hospitalizing the child, and anything apart from that you could manage on an OPD basis. Coming to what we would generally give, paracetamol is the only thing that we would usually generally advise in these children. We have a lot of commercial formulations where you have paracetamol with methadone. Now, we as pediatricians are highly against giving these, simply because they have a lot the side effect profile that entailed by mefenamic acid. You see children with a lot more gastritis. They end up coming back with vomiting, and there's a lot more that could go wrong. Suffice it to say, paracetamol is enough. Paracetamol is all that we use in Johns, and so paracetamol is all that you really need. And the general formulations that you have, and I've got an example to also show you how we calculated the doses, is we have a syrup of 250 mg bar 5 ml. Now, what we've written over here, 250 mg bar 5 ml and 125 mg bar 5 ml, is what we call the strength of a syrup. Okay, it tells us in 1 ml or 5 ml of that syrup how much mg of the medication is present. The usual tablets that we have is 500 mg and 650, and the usual suppositories. Again, suppositories are not something that we would usually recommend, but it's something that, again, is of common practice in burn centers. So if you must, it's worthwhile knowing that you have an 80 mg suppository and a 120 mg suppository as well. The general dose that we would give is 10 to 15 mg per kg per dose. This could be given maximum, usually 6 thali is what we would go, with a maximum dose of 90 mg per kg per day. But this 90 mg per kg per day could also be broken down into 4 thali doses, in which you can give up to 6 doses per day. IV is where we you have a range of 7.5 to 15 mg, but we would usually advise you to proceed with caution and try to just give a 10 mg per kg per dose. This could be given maximum 6 thali, with 60 mg per kg per day being the maximum dose we would give. So just to give you an example, for a 1-year-old child weighing 10 kg, what you would do is, considering you only have 255 mg syrup, we've established that for 5 ml, 250 mg is available. So this that would to say that for 1 ml, we have 50 mg of paracetamol there. For a 10 kg child, you would give 15 mg per kg. So that's 15 into 10. That is 150 mg per dose. So in order to give 150 mg of that of paracetamol, you would have to give 3 ml, because that would be 3 into your 50 mg equals to 150 mg. So your order which you would write is paracetamol or acetaminophen, 250 mg bar 5 ml, 3 ml SOS for temperatures greater than 100 degree Fahrenheit. Returning back to 2-year-old baby boy who is febrile, we have established that the mother has in fact checked temperature, and the child has been having fever since the past 1 day. You recheck the temperature as the child appears a little more flushed, and you establish the child is in fact having fever. So just as you've given, as you've shifted the child to your IP, the child ends up having GDCS, which lasts for about 10 seconds and is self-aborted. Upon reassessment of the child, 10 minutes later, the child is once again back to his normal activity levels, and neuro exam is unyielding. Of course, the diagnosis in this case would be febrile seizures. So to establish the diagnosis of febrile seizures, what you need is 3 things. 6 to 60 months, the general age group, in the setting of a temperature of greater than 38 degrees Fahrenheit, greater than 100 30 degrees Celsius, sorry, this is a typo, or 100 degrees Fahrenheit, in the absence of any prior afebrile seizures and not a result of CNS infection or any metabolic imbalance, seizures occurring in this triad of background triad would be considered as a febrile seizure. So what I've put here is two things: risk factors for further febrile seizures and risk factors for subsequent epilepsy. Now, the reason I put these up is these are the common doubts that that parents will have. Febrile seizures as such are not something that need to be treated unless they cross, tend towards febrile status epilepticus. There is the whole concept of giving intermittent clobazam prophylaxis, but by and large, those aren't required for a majority of the children. So what you would do, and as what's shown on the left-hand side over here, the risk factor for recurrent febrile seizures. If the child falls into a risk, a higher risk category where they are more likely towards having subsequent febrile seizures, in the background of parents who are highly anxious, it is under these circumstances that we would advise them to give intermittent clobazam prophylaxis. What intermittent clobazam prophylaxis basically entails is giving advising the parents to give the child clobazam, which is a benzodiazepine, 5 mg twice a day for the first 3 days of fever. And this would primarily be up until the child were to reach the age of 5 years. Okay. And the second thing that we would advise them is if they were to develop fever, to try to promptly correct that fever by administering paracetamol around the clock. So giving the child 6 hourly doses of paracetamol to ensure that the fever is controlled promptly. Okay. So what we would generally do in febrile seizures is first reassure, then counsel, actually stratify them and see where they fall in terms of recurrence of febrile seizure, and appropriately counsel them. Another doubt that they may have is that, okay, the child has developed seizures now in a background of fever, and you've counseled me that the child may develop this in the future. How likely is it that the child will end up having a fits problem in the future, having an actual epilepsy? So over here, I put up this slide to sort of show you that for just a simple febrile seizure, and we will tell you what that is, the risk for subsequent epilepsy is just 1%. It is only when we border on complex febrile seizure, on children who have a family history of epilepsy, in children who are neurodevelopmentally abnormal, where the subsequent risk for epilepsy is higher. And therefore, you would appropriately counsel them. And this would also help you decide on whether or not the child requires further evaluation. So coming towards differentiating between a simple and a complex febrile seizure, as I've thought a lot during our internship, a complex febrile seizure is defined by the Fs. F for focal, F for a duration greater than 15 minutes, and F for frequent, when there is a recurrence of febrile seizure within a 24-hour period of that first febrile seizure. So 2 febrile seizures during the same episode of fever, it is considered as a complex febrile seizure. Focality and focality is another thing that we would consider. And everything apart from this is a simple febrile seizure. So a GTCS lasting less than 15 minutes and an isolated episode is what we would consider as a normal, just a simple febrile seizure. Things to look for in these cases is doing a thorough neuro exam, ensuring that you don't have any post-ictal deficits, checking your meningeal signs. So in children where AF is still open, ensuring that it is just at level and not a bulging AF, checking your for neck rigidity and your Brudzinski's and Kerning sign. These are things that will help help you to look for whether there's any coexisting meningitis and whether the child would require LP and referral to a higher center. Okay. Moving forward, we come to another case scenario. A 1 year, 9-month-old girl with complaints of fever for 3 days, vomiting, increased irritability since 1 day. Heart rates, this thing on evaluation of the vitals, the child is tachycardic, normal BPs, and is febrile. Systemic examination is once again normal. Okay, for this, I would want someone to venture a guess. If I mean, you all can use the chat box, but in case you'll, and I would prefer it if you all were to unmute and tell me out loud. Anyone? Do we have any replies in the chat box?
Reena has replied. I catch her.
What did she say?
She said meningitis.
Meningitis. Okay, that's a very good guess. The one thing that would maybe go against meningitis is the fact that we have systemic examination, which is normal. I probably should have mentioned the AF finding over here, but the AF finding, one is it's a 1 year, 9-month-old, so it's already been closed. So here you would actually check for meningeal signs, and the meningeal signs which we've seen are negative. So the reason I put this up is in cases of fever with vomiting, one thing that we want to look for, or fever with diarrhea for that matter as well, is always look for a urinary tract infection. Now, something that you would ask the parents, I mean, younger children, of course, would not present with, that burning micturition or increased frequency. It would require highly vigilant parents to say that, okay, my child is urinating more than often, or that the child's urine smells a little funny, or that the child is crying, particularly in and around the time of passing urine. So always make sure that you do in cases where you think that the child is not looking too good, but it's not, systemic examination is very normal. You would want to consider urinary tract infection. Another thing to definitely consider in the guise of vomiting with even increased ability, given the season, would be dengue. Okay, so we've done investigations for this child. What we've seen is that there is some leukocytosis, which is neutrophilic predominant. Platelets are normal, thereby ruling out dengue. CRP is positive, which would indicate that there is some sort of infection, usually gram-positive. And the urine routine showing some amount of pyuria with elevated RBCs in urine as well, some amounts of trace proteins as well. So, but this would indicate is a urinary tract infection. So urinary tract infection, as defined by the new ISBN guidelines, it would basically entail infection of the urinary tract by significant titers of a single organism with a corroborative symptom profile. I've enlisted some of the risk factors over here. Coming to how the symptoms would generally be. So as the child ages older and older, you have more of your typical symptoms of urinary tract infection with fever, increased frequency of urination, dysuria. But when you look at the younger age group, the things that you would generally tend to see is just more of a fever. And a lot of times it would just be fever, increased irritability, poor feeding. And we've also talked about jaundice and all over here, because something that you have to look for in general in a younger child is whether the child is tending towards urosepsis. Okay. Coming to what you would do to treat these children. Now, I know urine culture is not available in majority and practically all of our burn centers. So the next best thing is to just do a urine routine, or to if you're able to convince your burn centers to buy dipsticks, you could just do a dipstick and evaluate for whether you have your leukocyte esterase or nitrates positives. So leukocyte esterase and nitrate positive would be an indication to start your antibiotics. And again, strictly according to guidelines, they would say that if the culture comes positive, continue the antibiotics. Whereas if it were to be sterile, to stop antibiotics and consider alternate diagnosis. For children who are below the age of 6 months, with a higher risk for urosepsis, you would anyway start the empirical antibiotics, whether or not your leukocyte esterase is positive. Whereas if it is negative, you would probably wait for the culture and start antibiotics if it were to come positive. This over here is basically to enlist sort of the duration you would go for. So the recent guidelines have established well that there's no inferiority of oral antibiotics versus IV antibiotics. So all you would actually have to do is to treat these children with oral antibiotics for 3 to 7 days if it's a lower urinary tract infection, cystitis, or if in case it was a pyelonephritis, an upper urinary tract infection. In these cases, you would probably look at giving a total duration of about 7 to 10 days. Another thing that I would probably want to address over here is, does anyone know for which children you would want to get an ultrasound done and which children you would not? For instance, for this child, a 1 year, 9-month-old, would you want to get an ultrasound done?
Dwani says when there's more than 2 episodes of febrile UTIs, then she would consider, or in a male gender.
Okay.
Soumya said no, she doesn't need an ultrasound.
All right, all right. So I mean, clearly you are all really well versed with what we've studied beforehand. So now, as per the ISPN 2023 guidelines, what they advise is to get an ultrasound done for all children presenting with first episode of urinary tract infection. Now, given when we're considering a center setting, you would have to consider the finances of the child as well. So it's in those cases that where you would look at the risk factors even in first episode, or in case of a recurrent episode, anything beyond the second episode, you would consider getting an ultrasound. But as per guidelines, strictly, they would say that it's worthwhile getting an ultrasound for any of these children. Now, the reason why you would get an ultrasound is, of course, to look for any abnormality of the urinary tract, to evaluate for whether there's any pelvic ectasia, and whether this child requires further evaluation by maybe a pediatric surgeon, or whether this child would require caphylaxis and prophylaxis in general. Okay, because what is said is when you have a dilated urinary tract, when there's anything that would predispose to stasis of urine, this would predispose to further infections, and in those cases you would probably want to prevent infections, and in those cases you would consider giving caphylaxis and prophylaxis. In terms of choice of antibiotics, the guidelines are very clear, where they would say that giving third generation cephalosporins or even your usual amoxiclav would work if you're looking at an oral formulation. And IV formulations, you would generally look at giving ceftriaxone. So to sort of go through the general ones that we give here in John's and what is generally given by protocol, we would generally look at giving cefixime. That's the usual one that we choose, which is the dose being 10 mg per kg in 2 divided doses. The strengths available of cefixime are 100 mg in 5 ml or 200 mg in 5 ml, with tablet of 100 mg and 200 mg also available. Okay, so coming again to a 1 year, a 9-month-old child, this child would probably weigh say around 15 kgs. So what we would generally look at is 15 into 10, 150 mg divided by 2. So that would be 75 mg. We would want to give 75 mg twice a day. So what that would generally entail would be giving about, if you're giving 100 mg 5 ml syrup, you'd give 3.5 ml twice daily for the duration specified earlier. So around 5 days if we're considering a lower urinary tract infection. Whereas if we're considering an upper urinary tract infection involved in the upper urinary tract, we would consider giving it for a longer duration of about 7 to 10 days. Amoxiclav is also something that we could consider giving. And if the child is not accepting orally, or the child is sick looking, we would tend to give the child ceftriaxone, 75 to 100 mg per, in 1 to 2 divided doses. Usually what we give is 75 mg per kg per day in 2 divided doses. So for that same 15 kg child, what we would generally look at giving is somewhere around 100 mg in 2 divided doses. So 50 mg IV BD of ceftriaxone. Okay. Are we clear on that? Do you all understand the ultrasound guidelines? Yeah. All right. So I will take silence as a yes. Moving forward, we have another child. I would look for some answers for this question as well, because it's a very common scenario that you will encounter. We have a 9-year-old boy with weight 28 kgs who is presented with high-grade fever for 4 days, myalgia, and he's describing a headache that is sort of retroorbital. Child also complains of vomiting since the last 2 days, inability to accept orally, with pain abdomen, specifically in the right upper quadrant. On examination, the child is febrile with some amount of tachycardia noted. Hemodynamics are more or less stable, but your CFT is just around 3 seconds, bordering towards 4 seconds. On examination, there is no organomegaly, but the child, as professed, is having mild tenderness in the right hypochondrium. Other systems examination is normal. Can anyone venture a guess as to what we're talking about here?
There's a lot of dengue.
Oh, okay. I think all of you have worked in journals during dengue season, so you're well familiar with what we're talking about here. As rightfully guessed, the child is having having thrombocytopenia with leukopenia, AST/ALT elevated, and your dengue serology, your dengue NS1 positive. So what we're talking about over here is dengue fever. Okay. Pathologic mechanisms I would maybe not go into, but the reason I put this slide here is to talk about antibody dependent enhancement. This basically implies that in your first episode of dengue, and as all of us have seen also during internship, the first episode tends to be not so severe. The second episode is where it tends to be severe, and the mechanism explaining that is your antibody enhancement. In short, the antibodies produced during your first episode of dengue are stored that as part of your immunological memory. During that subsequent episode, these antibodies are produced once again, and are non-neutralizing. They in turn lead to a cytokine storm, which can lead to vasculopathy and coagulopathy and lead to all the complications of the dengue we see and usually admit. So coming to the clinical manifestations, in the case scenario given over here, it fits the profile of dengue, of fever with at least one of these symptoms. With your case definitions as per your IAP and national guidance defining what probable dengue and confirmed dengue is. So you don't necessarily need to do a serology because in a lot of burn centers you don't have your serological test. So you may just have your card testing, which is not as sensitive or specific as your normal serological testing. Having just this symptom profile in itself with a corroborative blood CBC would be enough to actually start treating the child over there. And a lot of children will recover with just that. Things to note are warning signs and what is defined as severe dengue. So child with pain abdomen, persistent vomiting, with any signs of third spacing. So as we've defined earlier, dengue can lead to vasculopathy, which leads to leaky capillaries, where your capillaries are not able to hold the blood volume and a lot of plasma tends to leak out. This in turn can lead to ascites or pleural effusions. So children with any signs of that, mucosal bleeding on account of the thrombocytopenia, children who are in general have danger signs, or an enlarged liver, a tender hepatomegaly, with an increasing hematocrit and rapid fall in platelet. These are what would classify as dengue with warning signs. These are the children where you would consider admitting them or referring to a higher center in case you feel that your center is not capable of handling that. And anyone falling in the definition of severe dengue, where you have a child presenting with shock, okay, with fluid accumulation leading to respiratory distress, tachypnea with inability to maintain saturations, severe bleeding, or any organ involvement which is on the severe side. So elevated AST/ALTs, poor sensorium, things like dengue myocarditis, where you have massive tachycardia bordering on your 180 to 200 range. In these cases, you would most definitely want to refer the patient. What things that you could do, provided they're not third spacing over here in your center, is you could consider giving the child a fluid bolus and then referring them out. Or if you feel that you can reach a tertiary center within the next 15 to 20 minutes or within the hour, you would probably refer them immediately. Okay, this is to describe the natural history of dengue. I think all of you all are pros at that, but generally the reason I put up this slide is that your febrile phase is your first 2 to 3 days of dengue. During this phase, it is like any other viral infection, you would treat it as so. The only important thing, and the thing that I would probably harp on the most in terms of management of dengue, which maybe would be a little more specific to dengue as opposed to other viral infections, is fluids, asking them and encouraging the mother to give the child as much fluids as they possibly can. The next thing would be, next phase would be the post those 3 days is your critical phase, where you have plasma leakage and hemoconcentration. And it is in these cases where you may have to consider admitting the child if they have presented with either signs of third spacing, that abdominal tenderness, or when these children moving towards a compensated side of a shock picture. And then convalescent phase, where they return back to normalcy, which usually occurs after a period of about 7 to 8 days. So this is what the national guidelines for dengue say. Dengue without warning signs, without any risk factors. The primary risk factor that we would be talking about over here in the realms of pediatrics would be your danger age groups. So your dangerous age groups in dengue are infants and anyone in their adolescent age groups. Okay, so anyone who is dengue without warning signs, without risk factors, can be managed on a home basis or on an OPD basis, where you could ask them to come back after 2 to 3 days and repeat a platelet count and PCV to check that one, your PCVs are not rising too much, and two, that there's no dramatic fall in platelets. Generally, even if they were to have risk factors, you could treat them on a domiciliary basis. But in these cases, you would probably want them to come back a little earlier. So in cases of dengue without warning signs, without risk factors, you could maybe say come back in about 3 to 4 days. But with risk factors, you probably ask them to come the very next day, or maybe after 2 days, depending on their financial status and how far they were to stay. Dengue with warning signs is the case where you would probably consider hospitalizing the child, especially if there is a documented history of a prior episode of dengue, or if they were to fall in the danger age groups. And severe dengue is where you would tend to refer them to a tertiary care center. Okay. So enlisted over here are basically what I've gone on about till now, the criteria for where you would want to admit the child. As described in the natural history of dengue, when you have children within that group A, usually they would be in your febrile phase of dengue or a very non-eventful, critical phase. You would just ask treat the fever with your 15 mg per kg per day per dose of paracetamol. You'd advise the mother to watch for dehydration, watch for warning signs, and watch for the fever deficits, as that would indicate the onset of the critical phase. At this point, you would probably want to repeat at least a platelet count and a PCV, and you may want to just do a CBC, when deemed clinically necessary. In terms of Group B, your dengue with warning signs, what's important over here is fluid management. So as I've mentioned earlier, your fluid of choice in dengue would be NS, normal saline. Okay. The general progressions that we go through in terms of the fluid rates would be 3 ml per kg per hour, 5 ml per kg per hour, and 7 ml per kg per hour. So even in a child with dengue without warning signs, on account of either parental anxiety, or if you feel that you need to admit the child, you could generally start the child on just 3 ml per kg per hour. Whereas if you were to elicit any of the warning signs as enlisted earlier, the protocol has it, and what's seen to result in better outcomes is giving the child 5 ml per kg per hour first, at least for a duration of about 2 to 4 hours, and then subsequently coming down after reassessing the child. So if the child were to have, say, pain abdomen, severe abdominal tenderness on palpation, you would start the child on 5 ml per kg per hour. For instance, if you consider, again, a 15 kg child, because that's a number we've been using a lot in this talk, you would give the child 75 ml per hour for about 2 to 4 hours, and then reassess the child after those 2 to 4 hours and decide on whether you need to continue that fluid rate, or whether you can come down to a 3 ml per kg per hour. In this case, 45 ml per hour. Okay, and in all this time, once again, ensuring that the child receives adequate amount of hydration, is taking well orally. And what they generally say in the guidelines is, before coming down on fluid rates, it would be important to assess the hematocrit. Now, of course, we don't do that in a lot of tertiary care centers. So what we would generally recommend is, in a child where your warning signs are being aborted by your increased fluid rate, you can probably just do your PCVs, platelet counts and PCVs once a day. Whereas if it's a child that requires closer monitoring, you could repeat your PCVs every 6 to 8 hourly. Severe dengue, what I would say is that all you would consider doing is maybe giving this 10 to 20 ml per kg a bolus of NS at your center, and beyond that, it would probably be advisable to refer the child, because these children would require a more in-depth analysis and evaluation. So these children, I would probably chide you to not try and wait on them for too long, because we've seen that even from earlier referral leads to more successful and more rapid outcomes. So as much as we would want to cater to the patient's finances, it's also important to look at how their outcomes would be in terms of more prompt referral. Okay. One thing which you could add at this stage is if the child is desaturating, not able to maintain saturations, you could give the child oxygen as well. This is sort of to just describe how you would want to titrate your fluids. So not allowing the higher fluid rates to go on for more than 6 hours. So if you were to be starting at 5 ml per kg per hour, you would want after 6 hours you would want to try to come down to 3 ml, and so on and so forth. Okay. Have we sort of understood the basics of dengue? A thumbs up in the chat would probably help. Any specific doubts you would want us to address, or can I move forward?
Any doubts, you can add it into the chat box, and we'll go over it when we do the second part of the session.
Yeah. All right. So moving forward, here I've already put the diagnosis of community-acquired pneumonia. So this is again a very common presentation that we would see. Here we have a 3-year-old girl with a cough. Initially, on the first day, just a dry cough, and subsequently progressing to more of a wet-sounding cough for 2 days. The child also has noisy breathing since the last 1 day. On examination, you see that the child has a respiratory rate of 42 and is not maintaining saturations on room air. Would anyone care to comment on this respiratory rate of 42 in a 3-year-old girl? Again, we put the slide over here so you sort of have an idea as to what that would entail. Is the 42 a normal respiratory rate for a 3-year-old girl? Okay, so it would be something that is considered as tachypnic in this age group. Okay, the reason I've put that in is when we're defining pneumonia as per your IMNCI and as per your WHO classification as well, they're very strict about saying that only children with cough and cold, so corroborative symptom profile with fast breathing are regarded as pneumonia. Of course, on respiratory examination, you would also elicit findings of crepitations or wheeze, which would go in favor. But it's important to see that the child is also having these things in order to treat the child. So disposition, what would you want to do in these children? So since the child is not maintaining saturations, at this case, since the child would probably benefit from oxygen therapy, we would probably admit the child and treat the child with IV antibiotics. But what you would also look for in terms of deciding whether to treat the child on an OPD basis or an IPD basis would be to screen for your general danger signs, whether the child's feeding, the child's overall sensorium, whether the child has has had an episode of convulsions, or whether if the child is severely malnourished. So coming to what we would look for in these children, because a very common thing is to decide whether or not to give IV antibiotics. Viral pneumonias usually have some sort of a prodrome. So when these children, you would actually have more of a dry cough with sneezing at the onset. By and large, if the child were not febrile at the time of presentation, they wouldn't look so toxic. And these children usually spontaneously resolve on their own in a duration of about 3 to 5 days. What's important to look at in terms of bacterial pneumonias is you have 3 DOS presentations, or rather 2. Your typical pneumonias and your atypical pneumonias. Now, your typical pneumonias would warrant some amount of IV treatment. These are children who generally look more toxic, who have a faster progression of your pneumonia, and also have a patch which is seen on your X-ray. Atypical pneumonias are children who generally do not look so toxic, who fit under your classic definition of walking pneumonias. Running about in your OPDs look quite all right, but as still spiking fevers. On X-ray, you have some diffuse patches on diffuse heterogeneous opacities on your X-ray. And this is what would fit your atypical pneumonias. Now, why it's important to differentiate between a streptococcal pneumonia, staphylococcal pneumonia, and your atypical pneumonias is your drug of choice would probably change, with us opting more for an amoxiclav in these first 2, versus an azithro in cases of your atypical pneumonias. In terms of when to admit, again, always for your intuition and children who are just not looking that good, we would probably advise you to refer them, or at least, at the very least, admit them. But to follow more objective criteria, children less than 3 months with saturations less than 92, extremely tachypnic child, in these two cases warranting some amount of oxygen support. In cases of severe malnutrition, when there's intermittent apnea or grunt, or failure of oral antibiotics, the scenarios where you would probably think of admitting the child. So to just enlist how you would probably go about treating the child on an OPD basis, the commonly used antibiotic would be amoxiclav, though you could also go for just normal amoxicillin. The reason I've given amoxiclav here is to show you how we would calculate the dose. Okay, so even in amoxiclav and amoxicillin, you would calculate the dose of antibiotic based on amoxicillin requirements. Okay, so as enlisted over here, usually we would give the child 50 mg per kg per day of amoxicillin. So for a 16 kg child, you would require 800 mg in 2 divided doses. So that would be about 400 mg per dose. You want to give the child 400 mg in the morning and 400 mg at night. Now, amoxiclav is available as 2 syrups, 2 strengths, 457 mg in 5 ml and 228 mg in 5 ml. Now, you could ask me why these odd numbers are there, 457 and 228. The 57 and 28 are indicative of your clavulanic acid. So, as mentioned, we would calculate amoxiclav dose based on the amount of amox you want to give. So if 5 ml of amoxiclav contains 400 mg of amoxicillin, 57 mg of clavulanic acid, what you would generally do for this child would you would give 5 ml morning and 5 ml at the night. Okay. So coming to IV, what we would generally use as our first line again is amoxiclav, and this is a lot much easier dose. You would give 30 mg per kg. So you would give 30 mg per kg per dose. So for that same 16 kg child, what you would generally want to give is 16 into 30, 480. So roughly about 500 mg of amoxiclav 3 times a day. And you would continue this for a total duration of antibiotics of about 7 days. So that could be any permutation combination, 2 days of IV followed by 5 days of oral, or 3 days of IV followed by 4 days of oral. The general guideline which we would follow as to when to switch to oral is when the child is subjectively looking better, or number 2, when the child effervesces. Okay. Special situation, as mentioned, in terms of atypical pneumonias, you would consider giving azithromycin. So just to really drive the point back home as to what an atypical pneumonia looks like, it would be where you have bilateral lung involvement and there's no real patch, but you see these small whitish dots on both sides. So not really like your miliary pattern, but just a diffuse involvement of all your lobes. But the dose which you would give of azithromycin is 10 mg per kg per day for 5 days. Formulations available are 250 mg and 500 mg tablets with 200 mg bar 5 ml syrup and 100 mg bar 5 ml syrup. Okay, so if you were to consider that same 20 kg child, what you would do in this case is you would give the child 5 ml of azithromycin once daily for 5 days. Oseltamivir is another thing that we would consider for influenza. And the general dictum is, if you're considering influenza in a child, you would want to give oseltamivir within the first 3 days, within the first 72 hours of illness, because the effect of oseltamivir only comes in at these points. Oseltamivir is mainly to prevent any severe manifestations of disease from kicking in, and number 2, for more hasty resolution. So the general dictum that we follow is, for children less than 15 kgs, you give 30 mg twice daily for about 5 days, or for children, and you have all your weight bands here, so I won't waste time by going through all of them. But this is generally where you would consider oseltamivir. Considering that we come from St. John's, it is only right that we pay our developmental dues, and it would be incomplete of me to not mention certain developmental aspects which are worthwhile screening for during bond. One tool that is useful in these realms is the Trivandrum Developmental Screening Chart. So I understand that it is a little bit tiresome to go through, your entire developmental history on an OPD basis, especially during bond. That it's tiring for us as well as pediatricians. So what we have here is a tool that was developed in India in itself, which basically screens for developmental delays. So again, screening and not confirmatory test. It's to screen for developmental delays in children between the ages of. Can anyone tell me? Anyone put it in the chat? Downy points for you all. Sort of mentioned on the slide as well. So yeah. Any guesses? Okay, so generally we would look at screening for developmental delays in children aged between 0 to 6 years with the Trivandrum Developmental Screening Chart. Very simple to use this chart. All that you would have to do is draw to establish the child's chronological age. So either from their birth date, or if you're confident the parents are giving you a right age, find out how old the child is. So for instance, for a child 1.5 years, that is 18 months, you would draw a vertical line through the 18 on your x-axis, okay? And everything falling towards the left of that line, the child should have achieved. Okay, so here you see all these bars, and what these bars generally represent is the leftmost point is when 3% of children have achieved that milestone, and the rightmost point indicates when 97% of children have achieved this point. So definitely, if your child has not achieved a milestone where 97% of children have achieved that, it would be indicative that maybe this child is having some amount of delay. Okay, and so this is generally to sort of illustrate what we are doing for an 18-month-old child. This child should be able to throw a ball, walk with help, and so this limits the number of questions that you have to ask. Okay, what's important to note is that if the child is not is failing any of these things, it doesn't necessarily mean that the child is developmentally delayed. Positive predictor values are lower in this child, but what it is significant is that if the child is able to do all these things, it is highly unlikely that the child has any developmental delay. That is to say, the negative predictive value of this, your Trivandrum development scale is about 99%. So if you were to identify that the child is not having a developmental delay as per this screening test, it more or less is quite certain that the child isn't having that. Okay, so this is something that again we will share with you all on the group. There's a beautiful article which you all can go through in case you are unclear as to how to go about this. But using this would help identifying developmental delays. The other thing that we would advise you all to maybe do for children with a corroborative profile is to screen for autism using our MChat. So this is something I'm sure all of you all have done during your bond, the modified checklist for autism in toddlers. So this is just a very simple tool, and in fact, if you go to the autism website, they have it as an app where you just have to fill in yeses and nos. And what you have to generally do is identify whether there's any atypia which is identified. So for most items, yes is the typical response, and for items 2, 5, and 12, no is the typical response. So you identify the number of atypical responses. 0 to 2 is low, and in these cases, no further intervention. It's highly unlikely that they have autism. 3 to 7 is where they have a moderate risk for autism, in which case you would repeat the test again in a few months' time, and you would tell them the problematic areas and ask the parents to work on those areas. So say the child seems disinterested in other children. That is one of the areas of atypia. Child is not pointing towards objects to indicate that there's no proto-declarative pointing, where they're not indicating with a finger that this looks interesting. You would counsel the parents that these are the problematic areas, encourage them to work on those areas, and see after an adequate period of time, so maybe about 2 to 3 months, and specifically those questions, see if those areas have changed. If those areas have not changed, these are children who are at a high risk for autism, and you would probably refer them to a tertiary center or a center where they are equipped towards handling autism. Okay, so that early intervention is made in these children. And for children who have atypical answers for 80 to 20, these are children who have a high risk for autism and would warrant, immediate referral to a developmental center where early intervention is a possibility. To summarize this whole presentation, I'm sure I've told you a lot of things that you'll already sort of know, maybe just need revision on. But what is important to realize in pediatrics is that small corrections, just increasing your knowledge base by just a small amounts, can lead to a massive improvement in your children and the future citizens of tomorrow. So just to drive a few more points back home, and general advices that you want to give all your children is to avoid or minimize screen time. Number two, I've written just junks. Does anyone know what junks stands for? Is it just me making a spelling mistake? Okay, so the junks actually stands for something, which basically have J is, I mean, okay, so I won't waste too much of your time with what each of these things stands for, but basically these are different types of foods that you wouldn't want to give children. Okay, so they generally say that to avoid junk food in all your children as far as possible. But if you have to give in and allow for junk food, it would just be something that you would give once per week, and the amount of junk food that you've given on that day shouldn't exceed more than 20% of the calorie requirement of that day. The second thing that you would probably advise parents is to not use junk food as a reward, because if you were to project junk food as a reward, it further perpetuates the stereotype that junk foods are something that are highly viable. So this is how you would advise them regarding junk food. Another thing that falls under the purview of junks is your sugary drinks. Okay, so another thing which we may advise children sometimes by mistake when we are counseling about fluids is to give them a lot of juice. And it's important to know that one, you're giving your freshly squeezed juice and not your Tetra Paks, because these also contain a high amount of sugar. Sugary drinks and your Tetra Paks are again a big no-no, especially up to the age of 5 years. We all come from John's, and I think something that all of us have seen in John's is that we say no to bottle feeding, simply because bottle feeding is a nidus for infection and predisposes children to the two most common infections that we see in this age group. That being ARIs and your respiratory infections and your diarrheas. Number four would be deworming the child at every opportunity that you get. If the child hasn't been dewormed in the last 6 months, number five would be the red flags for development. And this is something that's available in your guide. So maybe just taking a copy of that or keeping a picture of that handy, so that you're able to identify developmental delays. Along with that, of course, using a Trivandrum developmental scale. Remembering to always check the anthropometry of the child, which has twofold benefits. One, being able to tell a mother who is complaining that the child is not feeding well, that the child is anthropometrically all right and actually showing them that on a growth chart. Or two, being able to pick out anthropometric abnormalities and being able to address it, knowing which children you have to spend some time giving nutritional counseling to. And of course, number seven, I hope through the course of this presentation, you'll have some idea as to when to refer children. Knowing when to refer is often a lot better than trying in vain to treat the child over there, despite our noble thought processes. Yeah, thank you.
Thank you, Mark.
I exceeded by too much.
Thank you, Mark, for this informative session. I know we are a little bit running late, but still, we'll take a 5 minutes break, and we'll be back with Dr. Nikit's session, where he'll be discussing all the doubts that you have put up in the chat as well as in the feedback forms that was given. During this 5 minutes break, you can take a little time to fill a feedback form about this session, so that we can help you better in the oncoming sessions. Okay, thank you. Okay, so I hope everyone had their breaks. Let's go forward with Dr. Nikit's class.
Okay. So it won't be too much of a class. I think Mark took a very comprehensive everything. And so just few tidbits I will tell you of how bond really changes your outlook towards pediatrics, and then we'll go questions. So I think one thing that I found very different from what, now I've learned pediatrics, and so I'm talking about it. And I think that's what you can see, emulate a lot through Mark, where he's trying to tell you this is what is to be done, this is what is to be done. But let's be honest, all of us have been at bond. We've all prescribed antibiotics for diarrhea. We've all prescribed whatever our nuns or the institution has told us. And I think it's important to realize that when you're working in bond, there's a lot more that you have to deal with than just pediatrics when you're dealing with children. It's not about doing what they do right in John's or doing what they do is best. It's also about sort of being more accustomed or being more accepted in a society that you're at. And I think that's a very important component to remember, because whenever you're at bond or you're at a center where you're, say, you have a pediatric load, but you have only an adult medicine specialist. And obviously, just because you're trained, you have a good backup in pediatrics, or you've studied pediatrics well, or, you still have a tie-up with your institution, so you can call either Mark or one of us and find out what to do with the child. Do not think that anyone in your bond center will see you closer to a pediatrician or will see you differently. So I think a very important component to remember is that when you're in bond, when you're in Paris, do as the Parisians do. You have to realize where to draw the balance between what to do to just be acceptable in the surroundings or be acceptable in the area that you're at. So having said that, I think the important thing I think that a lot of people brought up is that, see, when you deal with diarrhea in a bond setting, there are a lot of things that people want. So remember that drugs like metronidazole are very rarely used by anyone. So there will be a constant need by everyone in a bond center to be like, this drug is going to expire, use metronidazole. Child has diarrhea, give metronidazole. Right? So I think it's important for us, when you're treating, most as an MBBS doctor, that the first principle that you will always follow is doing no harm. Right? So that basically means that if you're going to sit at an OPD and you feel that this drug is going to have a harmful impact on the child, or you feel like this is not warranted for this child, then you should fight your battles and say, no, sister, I don't think this child needs metronidazole. But say this same child has come back to you on the third or on the fourth day, is still having high-grade fever, is still little sick looking. At that point, maybe even though you still think it could be viral, giving a drug may not change the basically outcome of this child. So I think that is something that you will realize also when you start treating a lot more viral diarrheas, is that with or without treatment, most children actually recover within 48 hours. So while sometimes or most of the times the credit is given to an antibiotic, I think it's important for you to realize and to choose your patients well. Don't if the parents are very persistent, or the parents are coming to you and telling you, child always responds to metronidazole, always we give this drug and the child becomes better. Well, there are harmful effects, but remember that most of these they're giving these drugs for like a day or two, and when the child is better, they will stop the medicine as well. So it's important to strike a balance between, is it really helpful or not, or whether it's actually it's more of a placebo effect than anything else. Right? And I think it comes a lot more as you start treating, say, in about 3 or 4 months into your bond, you will realize that a lot of patients technically will do well even without metronidazole. But if you have your own patients that trust you, or patients who have enough trust in you to know that whatever treatment you give, they will take it, or they will not basically go to another hospital or go to another doctor saying, this doctor did not give me antibiotics and that's why my child is still having diarrhea. I think it's about choosing the right patients for you to actually decide. So antibiotics definitely in diarrhea, I would think that if you have to consider giving a third generation cephalosporin. Metronidazole has a horrible taste. It makes them very attuned to not wanting to eat. It causes a lot of discomfort in patients. And so metronidazole, as far as I know, should not be something that we consider. Evaluating AGE at a bond center, I think, is very unrequired. I think you don't need to evaluate it at all. If you're, say, you're admitting for putting a line or things like that, at that point you may consider sending some blood samples for like a CVC, or looking at a urine or a stool routine to look at infection. Otherwise, I think it's kind of far thought to expect investigations for an AG, at least from the parents' point of view. And also, it's important to realize that a lot of children present to you with AG irrespective of the underlying cause. Dengue can present as an AG, UTI can present as an AG, pneumonias can present as an AG. This is all a subgroup of infections that we call parenteral diarrhea, wherein the cause is not really a GI cause, it's a non-GI cause of a loose stool. So I think it's important to recognize and to sort of look at GE more as a symptom than as a real condition by itself, at least in pediatrics. In a younger age group, obviously, we are a lot more aggressive with our management. And so it's okay to maybe consider giving antibiotic at that point. When older child, definitely not. It's a long, interesting debate of whether we should use probiotics in AGE. I mean, all scientific data actually points towards certain probiotics. So what exactly is probiotic? How does it work? I think all of us have sort of seen Sporelac and all of the different types of lactobacillus that is available. And I think the main role of that is to sort of, boost the local, flora, to sort of give a competition to the organism itself, to sort of prevent or improve gut signaling. So there is no harm with giving probiotics, though specifically they have been used more so in persistent diarrhea, in chronic diarrheas and IBDs, wherein you constantly are giving them antibiotics, and so it clears off the normal milieu. How effective it is in a routine diarrhea is actually how much of a studies we have done. We do not know whether the disease itself ended or whether it got improved because of us giving the probiotics. So there's still a lot of debate on whether we should give or not. If it is available and a child is tolerating it, I would still say it's okay with using it, even in a viral diarrhea. But its classic indication is in a persistent or a prolonged diarrhea. Then I think some other questions that you all had. Okay, so per-rectal, I think it's a very common thing that a lot of people, and all of us, even I have used it during my bond service, that everyone says as soon as the child comes, give the child per-rectal. Paracetamol, per-rectal diazepam, per-rectal diclofenac. Okay, so I think it's a great area which you can use to sort of administer drugs, in the sense that it does not require cooperation, it doesn't require the child to tolerate the drug. But it's important to realize, in a medical sense, if you want this drug to work, you want to see if this drug has an effect on the child, you want to know that the drug is being absorbed. Say a child who's dehydrated, who's not tolerating feeds well, who's not eaten well, okay, or has come to you, say, after eating very well, will have significant amount of food in the rectum. So your drug will actually not reach an absorptive surface to actually be absorbed. And there's a good chance that if a child has not passed through, the child will pass that stool along with because your medicine is going to act as a stimulant for a rectal, clearance of anything that is there. So it basically will stimulate you to pass stools. So there's a good chance that whatever drug you give will just pass out. You need to have an ideal candidate for the drug to be effective. That is a child who has received a bowel wash for about 24 to 48 hours, and then you give rectal paracetamol, maybe it will have the same effect as IV, or as close to IV as much as possible. But remember that that is not an ideal situation. Having said that, there's no real major problem with using it, except that it's so erratic. And most of the children, what happens actually is that you give the per-rectal and then you also advise them oral. So I think per-rectal is more of something you're using to allay the fears of people around you than to actually treat the underlying disease per se. Then what IV I am. Yeah. Okay. So combination drugs like paracetamol, ibuprofen. So I think the biggest problem or biggest concern we have with ibuprofen and mefenamic acid is that in a child who's dehydrated, or a child who's not doing like too well, or has had high grade fever spikes, there's actually a very, very good chance that these children have a propensity, that is at least a 30 to 40% chance of developing acute kidney injury because of the drugs, your NSAIDs that you're using. So I think there's a very small group of people. I mean, there are a lot of people who use ibuprofen and Meftal. I know a lot of doctors who use it on their on their kids as well, because they believe that paracetamol does not work. We've been giving it for so many days, and so Brufen works the best or Meftal works the best. There's no added advantage or disadvantage with using them. Only the fact that it causes worse gastritis, and the chance or the risk of AKI, acute kidney injury, is a lot more higher with Brufen. So there's no clear indication for it, though all of us have used it along with paracetamol as fever as a stopgap. Even after 4 hours, child has not gotten better, or say even after 1 hour of giving the syrup, the child has not responded to the paracetamol, then you could consider giving ibuprofen or mefenamic acid. But also important to look at, ensuring that the child is well hydrated, and ensuring hydration will be the most important thing in this. With dengue, I think it's a most important thing you should know is when to refer. Everything else comes secondary to that. Then anything else they have doubts about? It's already 8, so I'm trying to wrap up as quickly as possible as well. Let's look at my notes. I think there was a small doubt about inconsolable cry which was sent in. So I think inconsolable cry, I think, is a huge dilemma, not just for y'all, but also for us, as pediatricians, and also as a physician for you, right? So it becomes a very important thing for us to realize inconsolable cry can be anything, can range all the way from meningoencephalitis to just a blocked nose. So what I normally advise, or what I have normally followed, is to do a very detailed clinical examination, albeit very, very difficult to do in a crying child who's screaming, wailing, not letting you really examine or do anything. I think it's important to mainly look at the nose, look at the ear, look at the throat. These are the 3 things that prevent them from eating, breathing, talking, and drinking fluid, which is the most important thing that we will look at. So any inconsolable cry, that is one thing that I would definitely, ear pain, throat pain, all those things are very distressing to a younger baby. So these are things that I normally always make it a point to rule out in them. Things that normally always help in inconsolable cry is normally as soon as the child comes, if they say the child has inconsolable cry, I give them a start dose of paracetamol. So if it is an analgesic, if it is a pain-related problem, most of them respond to it. At least they become a little bit more calmer for you to examine in detail. Depending on the age group, maybe an infant who has just started weaning, 7 to 9 month baby, not passed stool, or has decreased passage of stool or recent loose stools, then there would be scope for you to do an ultrasound to look at intussusception. Though most of the times they will be a lot more sick looking than a child who's just crying because of a nose block or thing. So it's more symptomatic, and always giving paracetamol first thing when they come in. That ensures that you can cover for most problems that you would think. Then with febrile seizures, I know we say a lot of things, and Mark spoke to you about, okay, this recurrence, that recurrence, don't give intermittent prophylaxis. They will not see you as a doctor if you do not give treatment for a seizure, right? Remember that to a child, to a parent who has come with the first episode of a febrile seizure, it is very distressing for them, right? So as a peripheral doctor, there's no harm with giving clobazam, right? The only problem with clobazam is that it can actually mask a meningitis or mask an underlying more serious illness. So which is why I think it's about, if you are able to get through to them with counseling, or able to get through to them that a febrile seizure does not in any way affect the brain or development or growth, and if you think they're actively convinced about it, then I think you can do away with clobazam or frisium. If they're worried, admit them for a day, and over the day counsel them regarding the same thing. But in a small subgroup of patients, I think there is no harm, and I think a lot of doctors, including adult doctors and pediatricians in peripheries, do advise clobazam. And so yeah, I think there was a question about, should we give intermittent prophylaxis? There's no harm. There's no major harm that comes as long as you're absolutely certain it's febrile seizures. If you yourself have a doubt this is not febrile seizure, please do not give clobazam. Consider referral. But if you think that it is febrile seizure, clobazam, like I think Christina has put up, is given at a 0.1 mg per kg per day, or 1 mg per kg per day, technically in 2 divided doses. It's more of a, what do they say, like just to calm the parents down. that we're giving treatment, but honestly, it has absolutely no role in controlling febrile seizures, or it's just an anti-seizure medication. So it's just going to bring down your chances of you throwing a seizure, but can you still throw a seizure on clobazam? Yes. So it's based on, because by the time you reach or decide to start clobazam itself, normally a child would have had a seizure. Yeah, I think that's pretty much it. If you have any other doubts, I think we'll be more than willing to answer. Not just now, any point during your bond. If you think you want to discuss something at any point, please feel free to contact any of us from the department. Mark is anyways your first contact, I'm sure. Okay, I think with that, I have nothing else left. Is there any other questions that anyone has?
I hope everyone had their doubts cleared. And Dr. Mark and Dr. Nikit is there in the discussion group. So at any time you get any doubts, you can post those in the discussion group and they can answer at that time. Okay. Thank you everyone for joining us this weekend, and I hope you found the session on pediatrics very useful. I would like to extend my gratitude to Dr. Mark and Dr. Nikit, who have spared their time in their busy schedules to take this webinar. And I know that this has been a good session, and everyone had good use from this webinar. Okay, so we are at the end of this webinar. Hope to see you all next weekend with another webinar on dermatology. And thank you.
Thank you.
Thank you,
Thanks,
guys.
Joshua.